Hi, Dr. Hahn.
Hey,
Hi. I know, I
hi.
know. It's always a little celebration when everything when all systems go, right? How are
Yes, oh
you?
my gosh. Good, good.
Good. It's great to see you and be with you again and
You
speak with you
too.
about all of the latest. It looks like you alloy physicians down there had quite the time
Oh
in
my gosh.
Orlando.
I think it is a testament to the group that we have at Alloy. Just that we're all constantly wanting to learn and better ourselves for patients too, but also get to enjoy everyone in community where we're just like not just learning from each other, but we actually get to learn about one another like personally too.
Yes, it's a very unique coming together of people
Yes.
committed to bettering women's health. Um,
Yes.
so when I knew that you were going, and I knew that last week was happening, the Menopause Society Conference, I wanted to speak with you about your takeaways, sort of the biggest takeaways, so that um, we certainly at Alloy can always be like drilling down deeper on the current science, what it says, what we're bringing to our patients, and so on. But it sounded like, and correct me wherever I'm wrong, I wasn't there, obviously, so I don't know. It sounded like um, this year underscored how early perimenopause can start,
Yes.
how systemic menopause is, and maybe, I'm not sure if this is right, how much new data we have on heart, brain, sleep, and even gut health. Does that sound fair? And also,
Yes.
forgive me because I don't know how the conference works, so I don't know what you actually sat in on and what you didn't, and what you sort of walk out the door, with information to read about. But let's start with the early menopause, or how early perimenopause can begin, and let us know what your takeaways are from that.
Yeah, I think generally the conversation now, and I think this is sort of what Alloy is doing and what a lot of menopause practitioners are doing is having the conversations with patients early. And that means having those conversations even in like the early to mid 30s for preparation for what patients are going to go through. I think it was said in one of the lectures that it was at puberty or kind of the time leading up to that, we a lot of times are talking to maybe not as much, but of recent times we're having those conversations with our daughters, with younger women who are getting ready to experience a pretty large change in their lives. So why are we not having that same or similar conversation to prepare women for what they're going to go through in menopause?
Certainly.
So I think just the messaging was to hit home that yes, you can have perimenopause symptoms very early, even in, early to mid 30s, depending on a lot of times, just generally when your family members have gone through menopause, and kind of comparing that. And then also ethnicity and race plays a big role in that too, as far as timing of perimenopause symptoms.
I'm curious, Dr. Hahn, in your practice and in speaking with alloy patients, um, your years as a practitioner, is this news to you, or does this feel like actually I knew that? Because as a layperson, I heard that and I was sort of like, yeah, we knew that. We meaning like the women
Yes.
out there experiencing, right? So great that the messaging is what it is, but I'm curious as a clinician what it's been for you.
I've actually had a lot of conversations about this in the last week, especially over the time of the conference, because I think generally speaking in the healthcare fields, we a lot of times associate menopause symptoms with changes in menstrual cycles.
Right.
And that is usually the stopping of menstrual cycles or periods. We know now that a lot of times it can be the opposite, where patients are actually experiencing more frequent cycles or more frequent periods, and that's still a testament to that those perimenopausal hormone changes. But we know now that it's not all just periods, right? It
Okay.
is
Yeah.
it's so many other aspects. And so I think we're playing catch up a little bit, to be honest. I mean,
Hmm.
I think that a lot of us probably have the symptoms and we kind of just write them off a lot of times, right?
Hmm.
Because that's
Hmm.
also what we've probably been told, that maybe we're too young for perimenopause
Sure.
symptoms. But again, it's usually we're too young for perimenopause symptoms because we're still having periods.
Right.
And that just isn't accurate.
So let me hover there for a minute with you on
Yeah.
some of the other symptoms. And we've had occasion to talk about this, but what are some of the other symptoms that women may start experiencing in their early to mid 30s and so on?
Yeah. So I think in general, some of the most common ones that I see sort of in those that third decade where you're still having periods, but maybe they are getting more frequent. Maybe you're having bleeding in between cycles, kind of at random.
Mhm.
And then the fatigue component can set in. It's not all focused kind of on the hot flashes, night sweats, but you absolutely can experience those. And it doesn't have to be just those types of vasomotor symptoms. I have some patients who say, I just run hot now. I used to be able to sleep in pants. I was just having a conversation with a colleague about that. I used to be able to just like sleep in like almost sweatpants and socks and everything and get cozy. And now I have to basically sleep with almost nothing on because
Right.
I'm just run hot all the time. So that vasomotor symptoms, the classic ones that we think about, that might not be the case for earlier perimenopause.
Okay.
I see some patients who have pretty significant mood changes, or they may have like a new onset of an actual anxiety or
Wow.
depressive disorder. And they think, this is not me. Like, why are these symptoms happening? And a lot of that can be related to that perimenopause transition and menopause transition.
Yeah, I want to actually talk about the fatigue because if I'm not mistaken, that did come up as well this year, maybe more than in years past. I don't know. And sleep is such a big issue. I had a webinar recently with a sleep specialist, and it is one of those symptoms that I think for many women, myself included, um, I sort of wasn't realizing how poor my sleep was getting until
Yes.
I started taking estrogen and progesterone, and finally, very quickly, had a solid 8 hours of really good deep sleep. But I was just like, kind of like functioning, sort of like,
Yes.
I didn't sleep that well. So, can you speak to those two specifically? Because I know they're not necessarily one and the same either.
Yeah, I think that it's still important to bring up as an issue the fatigue portion to your provider, just because, there are obviously other things that we want to rule out too
Okay.
before we just also, put everything on perimenopause,
Yeah,
right?
thank you for saying
Um,
yes. Yeah.
yeah, so there are still other, lab evaluations and components to your physical health that we want to make sure that we're addressing as well. But for a lot of women, it is related to perimenopause. And a lot of times it is, we talked about the quality of the sleep that you do get, the duration of being able to actually stay asleep. They talked a lot about this term WASO, or wakefulness after sleep onset. And I think that rings true for a lot of us, where
Mhm.
we might have no problem initially getting to sleep, but then you wake up at 2, 3 a.m. and it's just you're wired, you're ready to go like it's a
Yeah.
full day. And being able to address that and actually get quality sleep, being able to go back to sleep, it can be a pretty big problem for a
Yeah.
lot of women.
Yeah. Thank you for that. So just to close the loop on sort of like the earlier perimenopause
Yeah.
piece, um, how should clinicians and women think differently now, in their mid to late 30s, certainly in their 40s, now that the timeline on perimenopause and
Mhm.
attention to it is shifting?
I think just understanding and approach. So I'll go kind of provider versus patient. So
Great.
for healthcare providers, I think it's really important for us to be open to the discussion, instead of kind of holding in our minds like, no, there is a specific cutoff, and that's all that, and that's it. And so I'm not gonna even gonna address or entertain the discussion, unless you meet these particular criteria. It's a very personalized journey for every patient. And, that doesn't even take into consideration a lot of times the patients who maybe were diagnosed with primary ovarian insufficiency
Mm,
or went into surgical menopause early. So it really needs to be a very nuanced discussion, but we need to be able to be open to those discussions. And for patients, I feel like, we kind of push this that you do need to be your own advocate, right? Like
yeah,
if you know that you do not feel like yourself and you have not felt like yourself for a very long time, um, it- it's not going to help you or be good for your overall health to
right.
continue to kind of write it off or ignore it. And so I usually encourage patients to really, if even if they're nervous about bringing it up with their provider, write out or put it in your phone, like a note in your phone,
Yeah,
a list of those questions. They're some of those questions might have pretty simple solutions, but some of them may warrant, a deeper conversation or even additional evaluation.
yeah.
But you're never going to know if you don't actually bring it up either.
So true, so true. And to that, and I know every clinician I've ever spoken with, yourself included, has encouraged people to kind of maximize your appointment when you're going into, let's say, your
Yes.
annual. It's not necessarily the best time, but you can perhaps schedule a longer appointment or let your physician know that you want to come back for a follow-up, or at least have a phone conversation for a follow-up because you have a list of however many questions that you'd really like addressed.
Yes, and I would say that is why building a good, strong relationship with your provider is so important. So not just throwing every possible problem that you have
Right.
ever experienced into one visit, because a lot of, my colleagues who are in, bigger health systems or especially the insurance-based models, you maybe have 10 minutes
Yeah.
to cover everything preventative, and then on top of that talk about what type of evaluation we may want to do, and then counsel you on options too.
Yeah.
That's a lot to put on a single medical provider, which is also why I always encourage my patients to have a team, so it's not all just on one provider or one physician, to give you all the answers. Still very important to have your team. Shout out to all of my primary care providers because they are truly the backbone of medicine.
Mm.
But having your team, your primary care provider, having your team of specialists, and utilizing those in a way that's going to be most effective for you and your own healthcare journey.
Yeah, and I would be remiss if I didn't shout out to Alloy as well, because you guys
Yes,
function like a team and you come together and
yes,
have clinical meetings and discuss um, certainly more challenging patients and how to come alongside them best. And we have access to you guys, on email anytime we want. So that's incredibly
yes,
helpful, fills a very big gaping hole. Um,
absolutely.
I want to pivot, Dr. Hahn, to hormone therapy. It
Mhm.
sounds like, and maybe this is a quote from the conference, but I feel like I saw several times, MHT is the gold standard for hot flashes. But what else did you learn, or maybe not, you already knew, um, about its impact beyond symptom relief? So I'm thinking about like the brain, the heart, or even longevity.
Absolutely. I think generally speaking, there was so much that was covered on hormone therapy and different aspects of care. I think one of the things that really stood out to me, because it's a conversation that we have, and it kind of goes back to the discussion of earlier perimenopause symptoms. One of the more important ones important points was the differences between menopause hormone therapy and, we traditionally call it birth control, but a lot of times I like to kind of switch it up and call it just cycle control, because there are still really good benefits to that type of hormone therapy versus what we traditionally consider menopause hormone therapy being sort of that bioidentical estradiol and progesterone. And then utilizing those and potentially starting earlier or talking to patients just more openly about what the benefits can be for one versus the other. They talked about benefits, potential for bone health.
Mm,
Those were the bone health portions were some of my favorite sessions, just because
really?
I feel like a lot of us in medicine, and especially even gynecology, we had probably very little educational component in
Yeah.
med school and residency just about bone health. And I think the tide is turning a little bit on prevention of bone loss rather than treatment, right? And this kind of speaks to um, the type of medicine that we're going to towards is more
Right.
the preventative type, instead of waiting for someone to get a disease process and then trying to put band-aids on or fix it.
What were some of the things you learned about bone health and MHT?
I think generally speaking, it's that we probably are not doing a great job of screening patients early enough.
Hmm.
I think one of the biggest shockers to me, I mean, I honestly, like, my mouth kind of dropped to the floor, was understanding that in perimenopause, before patients ever stop having periods, they can have a significant decrease in their bone density. So they have pretty large amount of bone loss within that menopause transition, where they may still be having regular periods, but they're actually losing quite a bit of bone density. And our general recommendations have sort of traditionally been to wait for an initial bone screening, unless you have another risk factor, until age 65. Um,
Whoa.
yeah, most women are going to develop that, at least low bone mass, or sort of the precursor to osteoporosis, far before that age. And so I think it really hit home to me that what we do in practice and what we recommend in practice, it
Amazing.
we need to sort of adjust how we're approaching bone loss for patients, because hip fracture or a significant fracture related to osteoporosis can be significant in terms of how it affects your quality of life and
Yeah.
then your health span as well.
Yeah, incredible. Thank you for that.
Yeah.
Can you talk a bit about timing of MHT? I know
hmm
we talked about this a lot in conversations. I'm pretty sure I saw a question come in about starting MHT after 60.
hmm
Can you sort of break down what we know to be the science and any changes that came up about that?
Yeah. I So there were kind of some back and forth
Oh,
in regards to this,
okay.
because I think it's the discussion, and some people again will kind of have that in their minds of, oh, well, you're over 60, it doesn't matter, I don't think you're a good candidate, or I think it's unsafe for you. When in reality, a lot of women don't go through actual menopause, like lack of 12 months without a period, until 57, 58,
Yeah.
59. I mean, you're going to tell those women, even though they're above the age of 60, that they can't have hormone therapy. I think we need to understand that aging itself is a lot of times what puts women more at risk for things like cardiovascular disease, heart attack, stroke, blood clots, all of that. And it's not just a discussion of hormones and
Okay.
whether you need them or not, right? It's more
Yeah.
so, okay, this is what aging is doing to your overall risk. But overall, if you are within that, we call it kind of the window of opportunity. So
Mhm.
if you're within that 10 years post menopause, and typically the studies have shown below the age of 60, then that is associated with sort of the lower risk category, right? But that's a risk category, right? That's not zero, and nor nor is it an absolute contraindication
Right.
if you hit 61, right?
Right.
So
Yeah.
so I think it really needs they hit home a lot in the meeting that it really needs to be a shared decision making process with your patient,
Yeah.
and not a cut and dry.
Yeah. Great. Great. How about mental health? Did that come up in anything you listened to? And as it
Absolutely.
relates to, I guess that's such a broad question, but I'm thinking specifically as it relates to MHT, and then any more about it, I suppose, as a symptom of perimenopause, maybe.
I think it was interesting because it was discussed. I don't think that we have the data at this point, particularly in perimenopause, because a lot of the studies that we're typically going to have is postmenopause just
Right.
because of the timing. But there's definitely an increase, and we know that in perimenopause. I don't think we have the data yet to say that menopause hormone therapy definitively
Hmm.
can be utilized as a treatment
Hmm.
for mental health. But I do think it's an important part of discussion. A lot of times, the mental health component, and we see this in premenstrual syndrome and premenstrual dysphoric disorder (PMDD). A lot of times, those mental health components can be triggered by significant changes in your
Yeah.
hormones related to your cycles. And so hopefully more research will come out about that. I did think it was interesting, an interesting point that they looked at vasomotor symptoms and how significant vasomotor symptoms can affect a lot of different aspects to health, not just mood, not just the lack of sleep and interrupting that, but also cognition, overall heart health, and mood as well. So,
I so appreciate you brought that up. You know, again, and I'm kind of trying to figure out how to say this because I'm not a practitioner and it's not like a coming up against medicine. It's more of like a it takes time to kind of be in lockstep, the
yes.
practitioner and the patient, or the
Yeah.
science and the patient. But for example, with vasomotor symptoms, again, this is anecdotal and personal, but I was out of my mind. I was really out of my mind. And I
Yeah.
share this a lot. I was experiencing 40 hot flashes a day. So this
Oh
was
my
just in my
gosh.
waking hours, not night sweats. But it also I didn't start hot flashing for about 9 years into what I understood was I was in perimenopause. So all of that time, I was experiencing other symptoms. And this is now
Hmm.
like several years back when it was sort of the conversation wasn't what it is now, right? The science
Yes.
hadn't met the moment in the same way and vice versa. But um, when I think about how debilitating those hot flashes were, it was a full body sensory experience and it went well beyond like
Absolutely.
a heat thing. I couldn't concentrate. I felt irritable. I got tired. I felt sort of like not myself. I was depressed. Like it was a whole lot of things that maybe I would believe a clinician would say that isn't all the hot flashing, but when you're struggling so much, muscling through that is not reasonable when there is
Yes.
help. And to your point, when it's impacting so much, I think,
So many aspects.
yes, I think understanding the resources available to you and not
Yes.
being afraid of them is critical.
I think it's tough because as clinicians, we a lot of times want to see something physical and
Yes.
or see a lab result that tells us what to do
Mhm.
or that guides
Yeah.
our treatment.
Yeah.
And that is not almost never going to be the case with vasomotor symptoms, right? Like,
Right.
except for the couple of times where I've seen amazing videos of like where people you can visibly see
Yes.
the hot flash happen, right?
Yes. Yes.
But that's not usually happening in your doctor's office.
Right.
Like,
Right.
so I think that's the tough part is for clinicians, a lot of times we want something we can quantify.
Yeah.
And we have to remind ourselves that that's not necessarily something you can do.
You know, it's exciting, and I know it's taking a while, but it is exciting and I think unique in that menopause care is so nuanced, and we're seeing in live time how it is so. And
Yes.
right, there are conversations that can happen with your menopause specialist that you may not bring to anybody else, but there's a knowing that you all have about sort of like the real world impact of all the symptoms and the
Yes.
symptomatology, and you can make sense of it for us, which is very exciting.
Yes, I think it also really does help and make a big difference when you've actually experienced some of the symptoms
Yes, I
yourself.
bet. Yeah.
Just the validation to be able to say to patients, like, oh my gosh, girl, I feel you.
Yeah. It's a
Like,
big deal. It's a really big deal. Um,
yes.
Dr. Hahn, how about anything related to body composition changes? Did that come up at all this year in the
It
conference?
did. And what I thought was really interesting, and I see this actually in my physical practice as well, because we use body composition far, far more than we would ever have somebody step on a just a normal scale.
Right.
But they talked about how in the perimenopause transition, you can see this packing on of the visceral fat component,
Hmm.
um, even when your patient has a normal quote normal BMI. We talk a lot, especially in the obesity medicine world, that BMI is unfortunately pervasive into how we prescribe, how we counsel patients, and how insurance sort of has dictated, who's a
Right.
candidate for medication. But in my practice, I see a lot of my patients who have had loss of muscle mass so significant that their BMI is still normal, but the component of their fat and specifically their visceral fat is significant. And
Wow.
we know that the visceral fat component is highly inflammatory. I have this conversation constantly with my patients. It is part of what drives the inflammation to blood vessels, to your other body organs. When you're packing on that visceral fat component, meaning the component like in your abdomen around organs,
Hmm.
it's also much harder to lose as well. So, knowing that we do have to take appropriate steps as a patient to be able to say, okay, I do actually need to change something about my nutrition status, my movement status. I can't do the exact same things that I did when I was 20.
Sure.
Really trying to hone in on that. But I think the big takeaway for me was yes, we are seeing a lot more patients who are normal BMI, but have a large component of visceral fat.
So interesting. And so, in addition to lifestyle mitigation practices, increasing exercise, shifting the type of exercise, sleep, I'm sure was a big deal as it
Yes,
relates to
yeah.
body composition, nutrition. Did GLP-1s come up at all?
They did. I think primarily in the context really of how it's a tool in the toolbox
Hmm.
for helping women and helping patients to manage obesity or, within that overweight BMI, but with medical conditions that are associated with that weight gain. I think there were probably a lot of questions still, and maybe questions that go unanswered because we just don't have the data to back
Yep.
them up as far as if a low dose of a GLP-1 or weight loss medication could be helpful. Again, I think that's where you really need to have a good working relationship with a provider that can give you the data, but then also talk to you about, okay, you you feel just almost you feel overall inflamed a lot of times in
Yes.
perimenopause. It's
Yes,
just,
absolutely.
and that happens so commonly. I have patients say that constantly. Like, I understand that I don't need to be back down to my weight when I was 15, but also I just don't feel good.
Yes, yes.
So I
Totally
think
get that.
it's a big conversation and a lot of pieces to it. And I'm hoping that we continue to have data that comes out, particularly in the perimenopause timeframe, because I feel like that's a lot of times when I see the most amount of weight gain
Sure.
as a trajectory than even compared to like several years post-menopause. That
Absolutely.
perimenopause time frame is just it
It's
wreaks
wicked.
havoc.
Yes, it wreaks havoc. It does. And I'm sorry to project. I just have to say I also like I gained 30 pounds during
Yes.
menopause and I was diagnosed pre-diabetic and I was like, what? Because
Yes.
it's that same thing we hear all the time from so many women. I'm doing all the same stuff or I'm doing
Yes.
more. Like I am so wrestling with my own physiology. You know, I
Yes. Yeah.
need help and a GLP-1 was like a savior for
Yes.
many of us.
Yeah. And I think we're going to see more studies coming out about not just the weight loss component, but also just its effects on inflammation in general and how that can be applied to other aspects of health.
Yeah.
We're already starting to see some of those studies come out as well. But I think that it's an important conversation to have with women. And it's a large reason why I am so interested in obesity medicine too,
Yeah.
because I see that as a huge component to the menopause transition. I mean, new onset cholesterol, new onset prediabetes or diabetes, where patients are like, I have never had an
Yeah.
issue with these labs before. And like, what is happening? New onset high blood pressure. I mean, so many aspects, and we know that cardiovascular health, I will like, I'll beat it till the cows come home that it's so important to pay attention to because we know that it affects women so much.
Yeah, yeah. Okay, so cardiovascular health, sleep, um, vasomotor symptoms, mental health, bones. We didn't talk too much about the microbiome or gut health. Anything there that was new or particularly outstanding to you?
Um, I think that in general, we're still, we have a lot of patients who lean towards supplementation of the microbiome. I think we're still grappling a little bit to find like great quality data as far as exactly what supplementation might be the golden standard, right? Like as far as, treating. I think generally speaking, for a lot of patients, prebiotics and probiotics can generally be helpful. They're not usually going to be hurtful
Right.
as far as like long-term use. But I think that overall, just understanding that the microbiome does change, and a lot of that can actually be, we see that in the vulvar vaginal area
Yeah.
quite a bit through
Yeah.
perimenopause and into the menopause transition. Like significant changes for women, recurrent urinary tract infections, recurrent vaginal infections that they've never had an issue with before. So I think there are still components to the microbiome everywhere that we're still needing more
Still
data
figuring
on.
out. And
Yeah.
to that, Dr. Hahn, the sexual health piece, was there anything that stood out to you, anything new that you walked away with?
I think in general, like sexual health overall, is just especially in perimenopause and post-menopause for sure, is there are so many aspects, not just physical, but also the the mental health component. And if you are, I mean, if you just think about it, like stop and think about it, if you are grappling with significant hormone fluctuations, significant mood fluctuations, and lack of sleep through perimenopause, that is 100% going to affect your interest in sex of
Sure.
any kind, and then also how your body actually responds, even if you do engage in intimacy of any kind.
Right.
So I think that one of the points that was hit home is that yes, we can look at labs, we can look at your tissue and everything, but if you don't feed that component of building a strong relationship with your partner that you're engaging with, then that a lot of those things are not actually going to be super helpful.
Right. This comment I just see now, just another thing added to our load that affects every single aspect. It's so
I
true.
know,
It's
it's
so
so
true.
true.
We are really loaded up. Um, Before I let you go, Dr. Hahn, was there anything that I guess you might walk back into your practice or, you know, share with your alloy patients that was like especially kind of jaw dropping for you? You talked about the bone health information being like a real enlightening moment for you. Anything else like that?
I think for me, one of the bigger ones that I try to talk to my patients about, but I definitely think I'll be having kind of more emphasis on with my early perimenopause patients, is that we kind of have this focus on bioidentical hormones, estradiol, progesterone, and that is like the only way. And we talk a lot about trans.
Oh, you just sort of got cut out.
Did I go out?
You're back. You're back. You
Okay.
said we
Okay,
have this
perfect.
emphasis on estrogen and progesterone, and that,
Yes. So emphasis that is has to be bioidentical, that the estrogen has to be transdermal or it's not safe. And I think that I have really come to realize like oral estrogen is still a very great option, especially for my early perimenopausal patients,
yeah,
as is sometimes the progestin, so maybe not the bioidentical progesterone, can be a very helpful component to menopause hormone therapy. It's not that you're taking like a full birth control pill or, again, what I like to call cycle control pill, where a lot of patients have had bad reactions or bad experiences with cycle control hormone therapy. We're talking about adding a component to it that helps a little bit more sometimes with the irregular bleeding portion, a little bit more with the significant hormone fluctuations through perimenopause. So just basically not to write off those options as unsafe or that they're not a candidate for them.
quickly, Dr. Hahn, I saw a question and I thought, will we get out of this time without a testosterone question? But we did.
Oh yeah.
So will you let us know what the word is on testosterone at this juncture?
Yeah, so I think Menopause Society in general really has to apply to the large number of practitioners who want to prescribe safely. And I think once again, the meeting itself just reiterated that we need an FDA approved testosterone version in the
Yeah,
US. And that, there's a wide variety of testosterone prescribing practices, but that the important thing I think is to focus on getting to a provider who is prescribing safely, is potentially monitoring that for you. And also that the data that we have is really primarily looking at testosterone for low libido or hypoactive sexual desire disorder. There's really not a ton of evidence to speak otherwise. But again, sometimes we have to take the data and the evidence from primary literature and pair that with what we see clinically as well. And so I
right.
think once again, just important to follow up with an actual provider who can help you.
And may I also, Dr. Hahn, just add, because I get this question a lot. why
Mhm.
Alloy doesn't prescribe it. And someone did share this with me that because it's a controlled substance and there are a lot of regulations around it.
Yes.
Prescribing in a digital health or telehealth platform is a little trickier. And at
Yes.
Alloy, we're super committed to bringing you evidence-based solutions and care. And unless we get the word that it is safe and we will remain aligned with our standards of care, we're not going to push the envelope, but rather just continue to follow the science. If that makes sense, does that sound fair?
Yes, yes,
Okay.
that is very
Okay.
fair. I think the biggest thing is just that testosterone, because we don't have an FDA approved version, we're a lot of times using a male prescribed version
Right.
and dosing it for female levels. And so that really does require actual in-person follow-up where you're actually having, oftentimes we're testing your testosterone level, especially as we're titrating up.
Right.
And that takes a lot of times a response to testosterone can take upwards of 3 to 6 months to really even see a baseline effect, depending on
Wow.
also what other components of hormone therapy that you're using. And so it's just very tough to do that in a telehealth platform. And also just because of, crossing state lines type of care.
Right.
So I'm hopeful that that will be, an option in the future. It's just really tough to do that now. But we definitely usually will recommend follow up with. You can go to the International Society for the Study of Women's Sexual Health website or the Menopause Society website, and find a practitioner if you are specifically interested in testosterone.
Um, my biggest takeaways in speaking with you today is nuanced care and shared decision making. Always.
Yes,
Is there
always.
anything else that you would leave us with today?
I just think that I'm just really excited about the conversations that are occurring, and I think that it's wonderful that they're actually occurring early and sort of in this preventative fashion instead of being 5 years into misery of hot
Mm,
flashes and
yes.
thinking that there's no end in sight and no hope in sight,
Yeah.
and realizing that you could have had, potentially had help all this entire time. It can be very isolating and make you
Yes.
feel very alone. And so I love that we're just Alloy is continuing to continue that conversation, and really educate.
I love that, Dr. Hahn, that the amplification of the um, preventative piece is ready to be louder. And I think for those of
Yes,
us who have mothers, who lived sort of with the
yes,
experience of having their hormones in particular taken away from them after the WHI study and the ramifications of that, and certainly the
yes,
messaging about no, you need to be afraid of hormones. I think that's being flipped on its head. And it sounds like
yes,
moving into 2026, there'll be a lot more sort of awareness of what nuanced care really means.
yes.
It's not a free for all, it's
Yeah,
a conversation with
I love that.
a practitioner who is well versed
Yes.
in menopause care. I love talking to you, Dr. Hahn.
Me
Thank
too.
you
I
so
love talking to
much.
you too.
Thank you so much. I will hit you up for more scheduling of all kinds of
That
conversations
sounds great.
in the upcoming year. Thank you for bringing the Menopause Society to all of us, the Menopause Society
Absolutely.
Conference 2025 to all of us. I appreciate it.
100%. Absolutely.
Thanks to
Thank you for
everybody who
having
came
me.
today. Thank you so much for your questions and your comments, and we'll see you soon.